Sneal.
My lady, may I call, please, Julie Pashley?
I do solemnly,
I do solemnly,
sincerely and truly
sincerely and truly
declare and affirm
that
the evidence I shall give shall be the truth,
the whole truth,
and
and nothing but the truth.
I hope you haven't been hanging around for too long.
No, thank you.
Ms. Pashley, could you give your full name, please?
Yep, Julie Pashley.
Thank you. Now, you've provided a witness statement to this module of the inquiry dated the 20th of June 2024. That's INQ 000486003, which sets out the experiences of your daughter, who was a young person detained in hospital in a children and young persons mental health services inpatients unit between March 2020 and June of 2021.
Yes.
Is that right?
Yeah.
I think when your daughter was first admitted, she was 16 years of age. Is that correct?
That's correct.
I think you are a mother of 2 children, in fact.
Yeah.
We're not going to name your daughter today if we are going to refer to her by the initials CB,
Yeah.
if that's all right.
Sorry to interrupt. Given that you've given your name, which is now public,
Yeah.
is your daughter all right talking for you
Absolutely.
to talk about her? I just wanted to check that, because obviously people will be able to identify her even if we
Yeah. Yeah.
don't name her.
Yes.
Thank you, my lady. I think your daughter was first admitted to a Tier 4, that's inpatient mental health unit, at the end of January 2020, is that right?
Yes.
And she was admitted as a voluntary patient, so she wasn't admitted under the Mental Health Act, is that correct?
That's correct, yeah.
And what was her diagnosis at that time?
So she was depressed, anxious, at risk of suicide, risky behaviour, and diagnosed autistic at that point.
Thank you. When your daughter was first admitted to that Tier 4 inpatient ward, you say in your witness statement that most things seem to function properly within the unit. How would you describe the culture or the atmosphere on the unit at that point?
It was really warm, friendly, open. It was designed to feel like home from home. It was families were involved, families were welcomed onto the ward. We were part of the care and that continuity of care.
Thank you. And then I think towards the end of February or beginning of March, you say that things changed on the ward as everyone was becoming more aware of COVID-19 and its risks. Can you tell us what changed on the unit at that point?
So we were no longer allowed on the unit. We could go to the family room. We had to wear a mask. We obviously had to use hand sanitizer. All the staff had to wear scrubs. They were also wearing masks. So we kind of lost that connection, I suppose, with the ward. So it became a gap between us and them.
And how were those new rules communicated to families?
Randomly, as and when they were brought in, I suppose. As soon as something changed, we were told relatively quickly, but it wasn't consistent. It was constantly changing, I suppose.
I think there was an incident on the 18th of March 2020 where staff believed that your daughter had swallowed a blade.
Yep.
And you were contacted, I think, by the unit to explain this. What were you asked to do then at that point?
So we were asked to take her to A&E to be assessed.
I think that was in a different hospital.
In a physical health hospital, not a mental health hospital.
And were you told whether you could bring your daughter back to the inpatient unit after you had been to A&E?
We were told we couldn't take her back to the unit because she was a risk, COVID risk to the patients and staff on the ward of the mental health unit.
So the concern at that point was, while she was in the A&E department, she could have contracted COVID.
Yeah.
All right. And how long were you told that she would have to stay away from the unit for?
2 weeks.
I think, given that, you made attempts to persuade the staff at the Accident and Emergency Department to undertake a COVID test.
Yeah. Yeah, testing wasn't routine at that point, and hospitals weren't testing on arrival. So we managed to persuade them. I'm not entirely sure. My husband managed to do that persuading. We managed to persuade the doctor to test our daughter for COVID so that we would at least get the result if we needed a negative result.
And did you get a negative result?
We did.
And so at that point, you took CB, your daughter, back to the ward. Was she taken back in? Was she readmitted?
No.
Did they explain why?
I don't think we'd had the negative result actually at that point, so they weren't prepared to take her back because they were taking a number of, well, probably over 24 hours to get the results at that point. So, yeah.
And how did you feel about taking your daughter home with you at that stage?
Absolutely petrified. She was obviously in a risk-taking mood. She had potentially swallowed a blade, so therefore she was clearly quite unstable. And we had to take her home and have her at home with us in our care for potentially 2 weeks, or at least hopefully until the negative result had come through.
Had she had any home leave during her inpatient stay at that point?
I think she'd had 1 or 2 one-night stays at home.
Did you explain your concerns about her risky behaviour and the risk she posed to herself?
Yeah.
Did you explain that to the inpatient staff?
Yeah.
And what was their response?
We cannot take her back.
Were you given any documentation to explain why she was being sent home at that point?
No.
Did there seem to have been a formal risk assessment undertaken?
Not that we were aware of.
Did they give you any, what's sometimes called safety netting advice? Did they give you any advice about where you could go or what you could do or who to contact if any of your fears were realised?
We could always contact, I think it was a crisis team number, but I'm not even sure they were 24 hours a day.
How did your daughter respond to being told that she wasn't able to go back onto the unit? What were her views?
She was anxious. She knew she wasn't safe. She didn't want to come home. We tried really hard to make it as possible and easy for her as possible to try, and we were quite sort of, it'll be fine, we'll all be fine, we'll get through it, it'll be okay. And we spent that evening playing games and trying to entertain and distract her from her own thoughts and feelings, I suppose.
If I can just take you back then to that point where the unit were saying they were not going to take CB back because of the COVID risks, the potential COVID risks, and CB was not feeling ready to go home at that point. Do you know whether CB communicated her views about her own state of mind and her own risks to the unit staff at that point?
She wasn't given the opportunity at that point.
So I'm sorry I had moved you back from that evening when you were she was discharged. So I think that was the 18th of March. Yeah. And you tried to distract her that evening. I think the following day or the following evening, your daughter did actually leave the home at night after you'd all gone to bed. Is that right?
Yeah.
And I think you were able to, once you realised that she was missing, I think you heard the front door closing.
Yeah, my husband heard the front door go. I didn't, I was asleep, but he woke me up. and of course we panicked.
And were you able to track your daughter?
Yeah, thankfully we've always had an app on our phones that we can track both of our children wherever they are.
And so you were able to
Yeah, we could see where
locate
she'd
her.
gone.
And where had she gone?
She'd gone about just a half a mile up the road to a bridge.
And what were your concerns then?
Then she was going to jump off the bridge.
I think, fortunately, you were able to find her.
Yeah.
And I think the police were also called and arrived shortly after you'd found her. Is that correct?
Yeah, so my husband arrived first and pulled her back off the bridge because she'd climbed over the barriers at that point. And then the police arrived around about the same time. They'd gone under the bridge first. She had called them to say, you're going to need to pick me up off the road so that no motorists will be hurt by my body. So the police arrived and at that time, and they were obviously quite concerned about her mental health. And we explained the situation that we'd had with the unit, and they called the unit to try and get her taken back there. That's where they wanted to take them back, and they were prepared to hold her under a Section 136.
What was the initial response of the hospital?
No, we can't take her back.
So I think you've explained that it was when the police mentioned Section 136 of the Mental Health Act,
Yep.
which enables them to hold a patient until they're assessed
Yep.
by a medical professional. Is that correct?
Yeah.
And at that point,
They gave in and said, OK, we'll take her back.
the unit took her back.
Yeah.
Thank you. Did the unit explain why they were reluctant to take her back?
It was still around the risk of spreading COVID.
And was there any discussion about isolation rooms, that she could be put in isolation when she
So-
came back onto the unit?
Yeah, we asked if she could go into an isolation room, and they said, no, they're for children who can't go home, who don't have homes to go to.
Once the hospital eventually agreed to admit her and to conduct a mental health assessment, I think the following day, in fact, the 20th of March, your daughter again expressed suicidal thoughts while she
Yep.
was on the unit and asked to
Yep.
leave the unit.
Yeah, she wanted to leave the unit in order to end her life.
But I think it wasn't until the following Monday, until after the weekend, that your daughter was formally admitted under
Yeah.
the assessment provisions of the Mental Health Act, Section 2 of the Mental Health Act,
Yeah.
which allowed her to be detained
For up to
pending,
28 days, yeah.
pending an assessment.
Yeah.
Did you have a conversation with the consultant at the unit about that assessment process and the likelihood of when she was going to be discharged from that?
Yeah, so we, her usual consultant said she was too unwell to be sent home, so she would be detained for as long as it was necessary to ensure her safety and to start the right treatment, which was a relief, huge relief, that actually she might get what she needed, and we wouldn't have to have her at home for a while. And then we moved on to, I think it was the 26th of December, was it lockdown? The day after.
I think she was formally discharged on
Yep.
the 26th of March, day 2 of lockdown.
Yeah.
Is that right?
So on the Monday, which I think was the 24th or 25th of March, I can't remember. The Monday we were told that she wouldn't be discharged, and then it was something about 24 hours later when a different consultant, one that didn't know her, said, no, she needs to be discharged. We need the beds for crisis.
And did you challenge that discharge decision?
Yep.
Presumably that
Got me
challenge
nowhere.
made no difference.
No.
I think you've explained that the discharge note dated the 26th of March stated that your daughter was extremely vulnerable, showed risky and impulsive behaviour,
Yep.
and it went on to explain that the hospital had justified the decision to discharge her on the basis that your daughter had asked to go home,
Yeah.
and that they were taking steps to limit exposure to COVID-19 on the unit. Is that right?
Yeah.
How did you feel after you read those discharge notes?
A bit sick, really. Again, really anxious, thinking, could we keep her safe at home again? Yeah, I think it was just dread, absolute dread.
Was there any care planning put in place for providing care to your daughter in the community when she'd been discharged?
I can't remember if it was that time or the next discharge.
I think you describe it in your witness statement as limited care planning.
That's right,
in
yeah.
place.
Yeah.
And the only support that she in fact received in the community was over the phone.
Yes, that was, yeah. The things were still quite tricky at that point with regards to community services. There was phone calls, so we could get a phone call from the community team, but that was it.
How beneficial would you say that support over the telephone was for your daughter in particular, given her autism diagnosis?
Absolutely useless.
And how did this second discharge from inpatient services seem to impact on your daughter and her attitude and trust in the mental health services system?
I think she'd lost all trust by that point. I guess she felt that nobody cared, that nobody was willing to look after her. She couldn't get the treatment she needed, the support that she needed. She just felt really let down. I think we all felt really let down.
Do you think that had an impact on her mental health at the time?
Absolutely.
In the first few months after she was discharged in March, how was CB coping?
She wasn't too bad at home. We managed to not have any significant incidents for a couple of weeks, which was really positive. She wasn't great, and she was definitely deteriorating from that point.
Was she able to engage with any community mental health services?
Not at that point.
I think CB was admitted again to inpatient mental health services, again as an informal or voluntary patient on the 15th of May 2020. And you've noted in your witness statement that it was immediately clear that the rules around infection prevention and control were more rigid but also more consistent.
Yeah.
Is this to the same unit that she'd been at previously?
Yes, yeah.
And this was a short admission with 72 hours crisis support on the ward, is that right?
Yeah.
And then I think your daughter made good progress during that period of admission.
I mean, I think she'd felt so let down. There was an element of she'd just hit crisis again quite quickly, and was taken back, supported, and realised that actually she'd rather be at home and she could manage at home, but with the right support at home, which seemed to materialise at this point.
I think she was discharged then on the 1st of June 2020, so just a 2-week admission period.
Yeah.
How was the care planning prior to that discharge and the community support that she received?
I think that's when it improved. I think that's when we had the key worker from Transforming Care came in, and we had the intensive support team coming out and visiting. So she was being visited at home much more regularly after that admission. And actually some of that started, so she was only in hospital for 3 days, although she was under their care for the 2 weeks. So they were putting in place that support in that time.
And how did that support seem to affect your daughter?
Positively. It was a real positive step forward.
I think then, was your daughter planning to try to resume her education then in the coming September.
Which was a huge progress for her. She was totally against education for a while and didn't see the point in any future planning at all. So we were really positive that she wanted to go to college.
I think she did have some concerns about the impact of her disrupted education.
She did. So although she was quite excited to go, as soon as she could think, oh, my GCSE results are coming, what if I can't get to college? What if I don't have the grades that I need to get into college? Because it was all teacher assessed and she'd missed most of year 11. So that sent her back down into a spiral.
And I think, unfortunately, her mental health deteriorated to the point that she was admitted again to this time on the 4th of August of 2020. Still COVID infection rules in place on the unit. At that time, there was some loosening of restrictions in the community, but not on the inpatient unit. Is that right?
That's right. Yeah.
And so, whenever your daughter had a home visit from
when she could come home,
she was having to then isolate when she went back on the unit. Is that right? And how long was she having to isolate for at that time?
In theory, it should have been 24 hours, but it was about 72 by the time. So they would test. So if she went back on a Sunday night, for example, they wouldn't test till Monday morning. Then that test would take at least 24 hours to come back. So it wasn't until they'd had a negative test that she could actually resume activities on the ward and leave her room.
So what would it mean to be in isolation then, literally in a room?
In a room on her own. There would be a member of staff not in the room. They would be outside the room for when she needed to. If she needed any support, I suppose, if they needed to do any interventions.
And how did your daughter find those periods of isolation?
Soul destroying, probably. I think that's fair to say. I can't even begin to imagine what it must be like as a healthy teenager to be stuck in a room on your own for that length of time. Never mind a mentally unwell teenager to be stuck in a room on your own with all your own thoughts and all those things that have led you to be in that place in the first place. So, it wasn't great.
I think outside of the periods of isolation at that time on that unit, your daughter did have access to some outside spaces and some green spaces.
Yeah.
She had access to her mobile phone and other communication devices at that point.
Yeah.
Was that true also in isolation? She was able at least to contact?
Yeah, she could always have her phone. She wasn't allowed a charging cable because of the risk of ligature. So we did manage to find a really short charging cable that she could use, and they would allow that in. But it was she could connect with us.
Another thing that you have noted at that time in terms of changes on the unit from pre-pandemic times was that staff were wearing PPE and in particular face masks. And I wanted to ask how that affected your daughter, particularly given her neurodivergence.
So if she can't see someone's face, I mean, she struggles with facial expressions anyway, but if you're wearing a mask, she has no idea what mood somebody's in, if they're asking something, what that tone is. She struggles quite significantly with that sort of communication. And she struggles to make connection with people anyway. So being able to see someone's face is really, really important to her, and being able to hear their voice and it's just, I think, again, it was quite isolating, I suppose.
So it was impacting on her ability to form a trusting
any
relationship or rapport with the therapeutic staff.
Yeah.
And speaking of staff, you've indicated that the staffing levels were noticeably lower on the ward at this period. And there was also more use of agency staff because permanent staff were sometimes absent.
Yeah, I mean, staff did get COVID, staff were ill, so they were off, and of course they were off for a long time. Some of them were very poorly. So staffing levels were affected, definitely, and then agency staff were brought in to fill the gaps if they can.
How did your daughter get on with new staff and making new relationships with those staff?
Not great. It takes her a lot longer to build a relationship with anybody, never mind a continually changing staff. I mean, she would struggle for the shift from day staff to night staff until she'd got used to that. So having different staff in each day, people that she didn't feel she could communicate with, and then faces were covered, then there's just, they were literally containing, I suppose, at that point. There wasn't really, she wasn't able to access the therapeutic levels.
In terms of therapeutic support, was there a move to remote delivery, so online video calls, telephone calls and so on? Was your daughter able to engage with remote?
No, she absolutely hates remote. Again, I think there is, when you're with somebody face to face, you pick up on feelings and other things that makes it easier to understand that person. When it's a 2D image, she cannot engage at all.
I think following an overdose in May 2021, so 13th of May 2021, I think CB was admitted again to inpatient mental health services, but this time to a unit 2 hours away from your home. Is that right?
That's right, yeah.
And is that because there wasn't a bed closer to home that was available?
Yeah.
And this time she was admitted under the Mental Health Act, Section 3 of the Mental Health Act, so she was detained on a compulsory basis at that point. And you've noted that the culture, if I can put it that way, on the unit was quite different. The staff were stricter.
Yeah.
But also that the rules around COVID prevention seem to be applied less consistently.
Yeah, so it would depend on who was on the ward to what the restrictions were. So the restrictions were similar to the previous ward in that if she went home, there were still issues, but some staff would let her out. If she was isolating, they would let her out. If nobody was in the corridor, they could get her outside so she could get some fresh air. But some staff said, no, you can't do that. You just literally have to stay in your room. And it just depended who was on.
I think at that time, if your daughter was allowed home for home leave when she was more stable, she had to isolate for 72 hours every time she came back on the unit. Is that right?
Yeah, if she stayed home, yeah. But
the rules were that if she went out of the unit just during the daytime, so she could go out for, I think you're saying it
was up to 8 hours.
Yeah, 8 hours daily. As long as that didn't involve an overnight stay, she didn't have to isolate when she was back on the unit. Is that right?
Yeah.
So at that point, you were presumably driving 2 hours from your home to the unit.
Yeah. Then we would drive her home.
Then you would go back to your home.
4 hours at home, and then we would spend 2 hours driving her back, and then we would drive home. So we were 8 hours in the car.
Driving every day.
Yeah. Not every day. We weren't that nice to her. We didn't visit that often, but we did. It was several times a week.
And on those occasions, your daughter had spent
4 hours in the car,
in an enclosed car with you.
Yeah.
You didn't have to isolate.
No, which seems bonkers, really.
But you explained that, in fact, you didn't want to do the overnight stays because of the impact on your daughter becoming so distressed from the experiences of isolation.
Yeah.
I think CB was then discharged from that inpatient unit on the 11th of August 2021. and was not too far off turning 18 and becoming an adult.
Yeah.
At which point, her responsibility for her care would move to adult mental health services.
Yeah.
Is that right?
Yeah.
So she was due to be discharged before she turned 18, and I think at that point she wanted to live in supported accommodation. Is that correct?
Yeah, she wanted to live in on her own. She didn't want to come back home. It was too traumatic for her to be in the house.
And what was your view of her moving into supported accommodation? Were you happy for that to happen?
I suppose it's a tricky one. I mean, you never want them to leave, but knowing her vulnerability, allowing her to live on her own was for us quite risk-taking. But we were assured that she would have supported living and that there would be support in place for her.
I think because she had been detained under the Mental Health Act, she then has a right to quite an extensive aftercare support package.
Yeah.
Is that right?
Yeah, so Section 117 aftercare, which is funded by health and social care.
And so did it appear, were you assured that that package was in place?
Yeah.
And was that the responsibility of social services?
The accommodation was, yeah. The accommodation was responsible for, I think it was children's services, because she was still a child at that time.
And so your daughter's discharged, you're told there's a care package available. I don't think she went immediately into any supported accommodation, though.
No. So we got home and I had a phone call from social services to say there was no placement, there was nowhere for her to go, she would have to stay at home. At that point, I mean, we didn't want her to be discharged because we didn't want her to not go into it supported living. We wanted her. We'd have, if she'd wanted to come home, we'd have had her home. There is no question. But she didn't want to come home, and we knew that pushing her into that situation of coming home would cause her distress and an escalation of distressed behaviour.
Was there ever an explanation of why that care package, which had been agreed to in principle, didn't materialise?
Because she was about to be an adult, so it would be adult social services problem. I
think, in fact, your daughter effectively ended up homeless.
Yeah.
And between September and December 2021, you did not know her location, you did not know where she was?
No, she cut communication to us completely at that point, which was upsetting, but understandable given that she just wanted to live on her own. She didn't want to be with us, so I think in her mind it was, right, if I cut off communication with them, somebody will have to do something.
So at that point, I think, was there any support in place from social services?
No. Well, she did have a social worker. But he didn't provide any support.
Did there appear to be any communication or cooperation between the Children's Mental Health Service or Children's Social Care and Adult Social Services?
No. So she was discharged from CAMS services, in principle to adult services. Adult services were not available for her because they didn't feel she couldn't access what they were going to offer, which was group therapy online. So she couldn't access that because of being autistic. So social services, so she had nothing mental health support-wise, and the communication between children's services and adult social services was adult services saying, we have to reassess, we have to do a full new assessment. Nothing. Children's services said now no longer counts.
All right. I think your daughter did eventually have access to a supported flat with a low level of support in December 2021, but it wasn't providing the level of support that she required at that point.
No, so she had a crisis in December when she finally got back in contact with us, and she was put into 24/7 support in a flat which was 1-to-1 for a couple of months, and then she went into a low-level flat after that.
And I think at that point, when she was in a low-level support flat, you explained that, in fact, her flat ended up being cuckooed by a drug dealer who was using the flat to deal drugs, sexually assaulted your daughter and beat her over a 3-week period.
Yep.
She became addicted to heroin and cocaine in that time.
Yep.
There was no one from the community mental health team visiting to check on her. And in fact, it was when she went to the police herself to explain what was happening that situation was brought to an end. After that point, she continued to ask for help.
Yep.
And I think it wasn't until June of 2023 when your daughter jumped from a bridge and broke her spine in 3 places that she was provided with the support that she needed from adult mental health services and social care services.
Yep.
Is that right?
Yeah.
Can I ask you, please, Ms. Pashley, what's your overall assessment of the impact of the COVID restrictions and rules on the care and treatment that your daughter received and her experiences as an inpatient during the pandemic?
I think it potentially delayed any progress in her mental health, any benefit, really, I suppose, to her getting any better, being looked after as well as she perhaps could have been. I think if she'd come out into the community with the services that were available previously, then maybe, again, we would have seen a better progress, a better prognosis, I suppose. I'd like to think we wouldn't have gone down the road we'd gone down, and she would never have jumped off the bridge. She would never have been cocooned. She would have had to have all those horrific experiences that she suffered, and us as a family. I think the trauma that the whole 2 years, 3 years put on our family was horrific.
Ms. Pashley, I've no more questions for you. Thank you very much.
Thank you.
Ms. Pashley, got to ask, how is she doing now?
Much better than she was. We've still got a long way to go. There's a lot of still stuff to unpick. There's a lot of trauma still that's sort of happened in the process of where she was. But she is much better than she was. I feel, I'm touching wood, that we're not at risk of loss of life anymore.
And I'm sure we all hope that. I don't know if you were dreading coming along or whether you wanted to talk about it or whether you felt it was a terrible thing to do, but you've been really helpful.
No, it's been a privilege, actually.
Sorry?
It's been a privilege.
Oh,
So.
well, it's been our privilege to listen to, even though it's an extremely sad and distressing story. Anyway, with your support, we all hope that she makes a good a chance at her life as she can.
Thank you.
As best a chance she can. Thank you very much indeed
Thank
for your
you.
help. Please.
My lady, I'd like to call, please, Dr. Guy Northover.
Repeat the words after me. I swear by Almighty God
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the
the
truth,
whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thank you. You can take a seat.
Hope you've not been waiting a long time.
Dr. Northover, could you give your full name, please?
So my name's Dr. Guy Northover.
Dr. Northover, you have provided an expert report on inpatient child and young persons mental health services for Module 3 of this inquiry, co-authored with Dr. Sasha Evans. It's dated the 23rd of July 2024, and it has a reference number INQ 000474300. Do you have a copy of that report in front of you?
Yes, I do.
And you're familiar with it?
Yes.
Thank you. Dr. Northover, you are a consultant child and adolescent psychiatrist, and I think you took up your first consultant post in 2010, is that correct?
Yes.
And you're presently working at Berkshire Healthcare NHS Trust in the Children and Young People Psychosis and Mania Pathway, is that right?
Yes, that's correct.
I think you've been the Trust's lead clinical director since 2016, and you have extensive experience working within and designing child and adolescent mental health crisis services.
Yes.
And I think between 2018 and April 2024, you were the Getting It Right First Time National Clinical Lead for Child and Adolescent Mental Health Crisis and Inpatient Services. Could you please summarise for us the Getting It Right First Time programme?
Yeah, absolutely. So the Getting It Right First Time programme is a national quality improvement programme that uses, it's a data-driven approach to identify across the country areas of variation, and that's followed up by clinical visits to sites to understand whether the variation is warranted or unwarranted. And then based on understanding whether it's warranted or unwarranted is providing support and recommendations to specific units or trusts on how they might improve. And that's been followed up by the creation of a national report with national recommendations.
Thank you. I think during the period of the report, which covers the relevant period of Module 3, that is the 1st of March 2020 to the 28th of June 2022, you were actively participating in the clinical reference group for children and young people's mental health, learning disability and autism services, where you chaired the data subgroup. Could you very briefly explain the clinical reference group for us, please?
Absolutely. So that's a clinical reference group which is supporting the specialist commissioning team for child and adolescent inpatient services. So it was a group of clinicians whose professional opinion was listened to help shape the specialist commissioning team's direction of travel.
Thank you. And I mentioned earlier that you've co-authored this report with Dr. Sasha Evans, who's currently based at the Mildred Creek unit at Great Ormond Street Hospital, and that's a specialist unit treating children aged 8 to 13 years. Is that correct?
Yes, that's correct.
If we can move briefly to the methodology of your report and the sources of information that you've drawn upon to produce that report. You've explained in paragraphs 26 to 29 of your report that you've obtained both quantitative numerical data and qualitative data to prepare the report. And I think it's right that whilst you've included statistical data where possible from all 4 nations of the UK, you observed that the amount of data available from England was considerably greater than that available from the devolved nations. Is that right?
Yes, yeah, that's absolutely right.
And you've also observed that the number of child and adolescent mental health services inpatients in the devolved nations is a small number, and sometimes those small numbers means it can be difficult to identify whether a trend is statistically significant from that data. But nevertheless, is it correct that in your view there's been no obvious divergence or difference in the trends observed between the 4 nations of the UK?
Yes, I mean, that was absolutely the interpretation that we took from the data we were able to see.
Thank you. Now, Dr. Northover, I'm going to ask you to help us today with a number of the topics that you've explored in detail in your report. Firstly, I'm going to ask you to give us a brief overview of the outline of provision of mental health services, inpatient services for children and young people across the UK. And then I'm going to ask if we can go on to look at changes during the pandemic to the number of young people admitted and discharged from inpatient care, and changes to the care and provided in those inpatient units, and how those changes impacted upon patients' experience. And then I will be asking you for your reflections on the impact of the pandemic on CAMS services and your recommendations for future pandemics. Can we begin also with some terminology? Because we've heard children and young people's mental health services and child and adolescent mental health services. Is there a difference between the two?
I mean, there isn't. And of course, there's the third terminology as well, which is children, young people, mental health. And it is confusing, but they all mean the same thing. It's just where it's used in different policy teams and within different trusts. And I probably have to apologise in advance to say that I will be shifting between the three terminologies myself without realising it.
Well, for ease of reference, I'm probably going to be saying CAMS because it's less of a mouthful than the other acronyms. So can we begin, please, with a brief overview of the inpatient sector? And could we look, please, at page 16 of your report? This is table 1. Thank you. And we can see there the number of inpatient units and beds in each nation. So we see that in England, there's considerably greater provision. It's a larger country, with 59 units, 6 of which are for children. What does it mean to have a children's unit? What age group is that?
So a children's unit is up to the age of 12. So there's theoretically no lower age limit to these units, but it would be very unusual to admit somebody to a children's unit who's under the age of, say, 6, 7 or 8 years old.
Thank you. We can see also there are low secure and medium secure units there. Is that for forensic units, as they're called?
It is. It is slightly different within child and adolescent services to how it is within adult services. So a medium secure unit is what you would think of as a similar secure unit in adult services, where young people within a medium secure unit will have a court order to be within that unit. So due to their mental illness, they will have committed a crime that requires them to be within a safe environment. Within child and adolescent services, a low secure unit is more often used for young people who are presenting with significant challenges in terms of their behaviour and self-harm risk that mean that they are that it's difficult to manage them within a general admission unit. So they require a higher level of security. And that would be security in terms of sort of locked doors, security in terms of the more restrictive policies and procedures, and security around the staffing than they would do within a general admission unit. But they're unlikely to be there because of a court order.
Thank you. And so we can see there that in England there are in total about the 1,300 beds that are available. In Scotland, is this a general adolescent unit, GAU? There are 3 of these providing 54 beds, 1 children's unit providing 6 beds, and in Wales, 2 general admission units providing 30 beds, and in Northern Ireland, 1 unit with 2 wards providing 25 beds, plus an additional, what's a PICU bed?
So a PICU bed is a psychiatric intensive unit. So again, that's similar to a low secure unit, but a young person would only be expected to stay a short period of time on a PICU unit before going back to a general admission unit.
Is that a psychiatric intensive care then?
Yes.
And we can see there that the low secure units and medium secure units are provided in England. I think it's right that if there are forensic admissions, those are the units that are used for patients from Scotland, Wales or Northern Ireland. Is that right?
Yes, absolutely. During the time of the report, that was the case.
We can take that down now, thank you. Can you help us, please, Dr. Northover, with the nature of the mental health presentations that are seen in inpatient CAMS services? Why children and young people would be admitted to inpatient care? And
as we've just seen, across the 4 nations, there's only just over 1,400 400 beds. So it is a very small proportion of young people with mental health difficulties who end up being admitted into a psychiatric inpatient unit. And it's not necessarily just the type of presentation, the type of mental illness, it's also the extent of the presentation. So you will see young people with very severe mental illness. They might be presenting with a psychotic illness, they might be presenting with a mood disorder with serious self-harm, but it's also about how that is an illness that can't be treated in the community. And it may not be able to be treated in the community because of the degree of risk, or again, the degree of security that the young person will need, or it may be that they can't be treated in the community because of the intensity of the support that is required. And when it comes to the intensity of the support, the majority of young people admitted into these units are admitted in a crisis as an emergency, but a smaller proportion are admitted for a planned admission. And that would be for where the admission is part of a care pathway, where the community element of that care pathway has come to the end of it's what it's able to provide. So, for example, if you're starting specific medication such as clozapine in somebody with psychosis, that's something that should almost always happen with an inpatient unit. You may have somebody who has very, very severe OCD who's not able to leave the home, who needs more intensive therapeutic support within a different environment.
Thank you. And you have mentioned there referrals. I think referrals to inpatient services are made by community CAMS team, the Tier 3 CAMS team, is that right? Or from a crisis presentation at the emergency department, as you said. So when a referral is made, is it right that staff on the receiving unit are the ones who make the assessment of whether it's appropriate to admit?
So the appropriateness to the initial assessment is carried out within the community, and it's not usually carried out by the inpatient team itself. So that assessment would usually be carried out by a crisis service or somebody who specialises within the crisis assessment, and then a recommendation for an admission would be made by that team. And then that recommendation would be reviewed by the inpatient unit, who would then decide whether it is appropriate or not for that young person to come into their inpatient unit.
And so would that decision usually be made by a psychiatrist?
It's usually a multidisciplinary team, so it's usually not a single clinician who'd be making that decision. It would be discussed within a multidisciplinary team to decide whether the treatment available within that unit is actually going to be able to support and treat the young person who's being referred.
You set out in your report that the majority of admissions into inpatient CAMS units are voluntary, so they're not compulsory detentions under the Mental Health Act. Is that right?
Yes. Yeah.
But I think it's also possible that a patient could be admitted voluntarily and then be subsequently detained under the Mental Health Act.
Yes. Yes, and the recording of admission, the use of the Mental Health Act is not as good as the recording of people who are admitted under the Mental Health Act. So we don't have the high quality data to know how many young people were assessed and then admitted but not detained, and how many were assessed, detained and then admitted. And so when we say detained, that's when under the Mental Health Act that the young person is placed under the section of the Mental Health Act on admission.
Can you help us, please, aside from the Mental Health Act, but the admission criteria for admission to an inpatient CAMS unit?
Yeah, so the admission criteria would be, first of all, that the treatment can't be provided in a less restrictive environment. So an inpatient unit is a very restrictive environment. The doors are always locked. The young person is not able to get out unless they are asked and unless they ask and they are accompanied. The second part is that the unit must have an intervention that is going to support that young person. So if the young person needs to have a mental illness that is going to be able to improve through the process of admission.
And what would be a reason for declining to admit a young person who's been referred to inpatient services?
So the main reason to decline would be that there is a community alternative that is less restrictive. So again, if the inpatient admission is for therapeutic support and that can be provided elsewhere, then the inpatient admission wouldn't need to be taken ahead. The other reason would be that the inpatient units may not be able to provide the level of intervention or the type of intervention required. So for some young people, going into an inpatient unit with its restrictive environments can actually cause a worsening of the presentation in the initial admission. And there is that question about, is that worsening of the presentation going to be in that young person's best interests or not?
And if there's a referral made to a unit and there isn't actually a bed available in that unit, is there a process by which it's possible to see if there is a bed available outside of that local area?
Yes. So around about 20% of all admissions, that's been quite consistent actually for a number of years, around 20% of admissions are for young people outside of their local area. So what we describe it is we describe it outside the natural clinical flow. So we try not to use distance as the factor about whether a young person is admitted to the right place, but whether they're admitted to a unit that has strong links to the local community teams, so there can be the appropriate level of in-reach and the discharge can be managed as a single pathway rather than it being from a different pathway. And as I said, we know that around about 20% of admissions are outside of that area, which would suggest that the health service in that area has had to seek a bed further away.
Can we move on now, please, to the pandemic period? And first of all, to look at admissions during the pandemic. You've identified in your report that the data shows a decline in the number of admissions, the number of young people admitted across all nations of the UK during the pandemic. What were the reasons for that decline in the number of admissions, in your view?
I mean, it is multifactorial. The report also indicates that there was a decline in the number of beds. So beds had to be closed for a number of reasons. So in some circumstances, because of social distancing and the potential that there was multi-occupancy rooms, that those rooms had to become single occupancy. We know that because of staffing levels, some units had to be closed, and I think the report indicates throughout the pandemic, between 5 and 7 units at any one time were closed within England. So the decrease in beds would have caused a decrease in admissions, but then the process of admission itself became more difficult, and the criteria I mentioned before around whether the unit is able to provide the appropriate intervention or whether it's going to be a better place for a young person shifted and changed. So, for example, if somebody needed more intensive therapeutic support, but the therapists were, through social distancing, doing the majority of their therapy online, then actually there may be little benefit for that person coming into an inpatient unit. And on the other side, when you during the period of self-isolation, when young people were being put into the situation of self-isolating in their bedroom for a long period of time, again, the risk of a deterioration of the young person's presentation increased, so potentially the criteria for admission changed.
Thank you. Do you think that this change in the potential change in the criteria for admissions on the part of professionals meant that the profile of the patients who were admitted changed, so that it was only the most acutely unwell or the most at-risk patients who were then admitted to patient care?
I'm sure that the profile changed, but one of the factors that looking at the risk and the intensity of the presentation is if we look at the number of young people who were admitted under the Mental Health Act, and that didn't statistically change during the period of COVID. So if we were expecting only young people with a much higher level of presentation to be admitted, we would have expected to have seen an increase in the number of people detained under the Mental Health Act.
Is that because the criteria for detention under the Mental Health Act makes reference to whether that young person is a risk to themselves or others?
Yes, absolutely. However, there are other areas that we can see there was a change in the profile. So when speaking to the units in Wales, the units indicated that they had to have a change in their process of admission because it was no longer possible for them as a unit to go out and assess every young person before the admission. So,
and was that the situation prior to the pandemic in Wales?
Yes. So that meant that the units were less able to assess a young person based on the therapeutic milieu and the young person's presentation. So the types of admission that they were getting may have changed a little bit.
And once the decision was made then to admit a young person, in pre-pandemic times, how long would it usually take on average between that referral decision and the young person arriving on the unit?
I would have to check the graph to see, but I do know that time went up during the COVID period.
So there was a longer, I think we can have a look at figure 8 on page 28 of your report, please. And this is the average wait times. I'm not going to ask you to explain the difference between median weight and mean weight, unless you very much like to, but we can see that by either metric,
Yes.
the length of time waiting increased.
And my understanding of this is what we're seeing a bigger increase in the very long waits for an admission than we were seeing an overall increase in waits. And that can also be held up. So I think that when we were looking at the very worst, I think the report identifies in one instance there was a wait of 111 days for a bed. And this, again, becomes quite complicated because this was happening at a time that community services were transforming and providing more community care for young people with who are presenting in a crisis. Within child and adolescent mental health services, young people who are being admitted, you quite often find that there are young people who are being admitted who have significant social deprivation and social challenges. And in those circumstances, sometimes identifying a social care alternative is a better therapeutic approach than a mental health inpatient approach. And understanding that prior to an admission can sometimes take a long time to resolve.
Taking aside those outliers, do you think there were reasons related to the pandemic and the pandemic countermeasures that resulted in an increase in wait times?
Yes. So again, in terms of assuring the physical health status of a young person prior to admission, that added additional time. So again, when COVID testing was being done to ensure that the results of the COVID test were back, the fact that it is difficult for an inpatient unit to manage more than one or two young people who are self-isolating at a particular time. So whilst the bed might have been available on the unit, the ability to admit multiple young people at the same time may have changed as well.
And you explain in your report that whilst some of these children, whilst they were waiting to be admitted to a CAMHS inpatient unit, would have been kept on an adult ward, an adult psychiatric ward, is that right?
So again, we did see an increase in the number of young people who are being admitted to an adult psychiatric inpatient unit prior to going to a child and adolescent unit. And that was a double whammy of challenge, because the young person would be in an inappropriate environment because they'd been in an adult environment where they would have to self-isolate, and then once a bed became available, they would then have to move to a child and adolescent inpatient unit where they would have to self-isolate again.
And what is the impact on a young person of being kept on an adult psychiatric ward in terms of their access to therapy and their progress towards eventual discharge?
A young person on an adult ward has to be accompanied at all time by a member of staff. So there's that one-to-one staffing has to be in place. The young person on the ward is usually kept, if not separate, they would usually not be part of the group therapeutic interventions on the adult ward. The therapists on the ward themselves may not have the training or the expertise to support a young person in those circumstances. So when COVID wasn't an issue, you would usually find that a CAMHS therapist would come from the community to support the young person whilst they're on an adult ward. However, during COVID, that was something that was far less likely to happen.
Thank you. I think data also showed an increase in the number of young people in an acute hospital setting awaiting a specialist CAMHS bed in England. Is that an acute paediatric ward?
Yes.
And how would admission to an acute paediatric ward rather than an inpatient CAMS unit impact on the care and treatment of that young person?
So the majority of the time, it would be a negative impact, because the majority of the time that young person wouldn't be getting the psychological support that they need. So we know that there's been feedback from paediatric wards that the staff don't feel that they've had the skills or the expertise to support young people with mental health problems. So there's absolutely a delay in the treatment. However, there are some circumstances where being on a paediatric ward is the right place to be. So, for example, if the young person has a physical health problem at the time, if they've taken an overdose, then that's where they need to be whilst their physical health is stabilised. And also with eating disorder presentations, there are a number of areas within the UK that operate a model where a young person with an eating disorder will be supported and managed on the paediatric ward if they require refeeding, if they require NG tube feeding prior to a discharge back to community care.
And I think it's right that there was a significant increase in eating disorders during the pandemic. Were other mental health conditions also observed to increase, or was the greatest increase seen in eating disorders?
The greatest increase was absolutely seen in eating disorders, and that's partly because eating disorders is it's the mental illness that's got the highest rate of fatality, and it's a mental disorder that becomes quite obvious to everybody as the weight drops.
And do you have a view of why during the pandemic there were more children and young people presenting with eating disorders?
Yes, so one part of it is school. Schools are absolutely fantastic in providing social support to children, and also being a safety net for children who may be starting to show deterioration in their mental health and with eating disorders. The second part of it is if you have a mental illness and you end up within your family home, then there's a risk, particularly with eating disorders, that you end up in your bedroom, that you start isolating yourself further, and you start getting drawn into some of the behaviours that led to the eating disorder starting in the first place.
Can we have a look, please, at the witness statement of Dr. Elaine Lockhart? She's the chair of the Royal College of Psychiatrists Child and Adolescent Faculty. At paragraph 31, she makes this observation about the changes in the presentations of young people to mental health services during the pandemic. She says this: following an initial decrease in the demand for CAMS in the early months of the first lockdown and over the second lockdown, although less significantly, we have heard from our members that children and young people who then presented to services were more unwell than had ever been seen before, and in a greater volume. It is not simply that presentations and contacts with services increased, but rather the nature and severity of mental ill health among those presenting had worsened markedly. Do the observations of Dr. Lockhart, repeating the concerns of members of the Royal College, correlate with what you heard from CAMS inpatient staff that you spoke to in compiling your report?
Yes, absolutely. Yeah.
You also observe in that report an increase in admissions from more deprived areas, and you mentioned earlier those social indicators of poor mental health. Did you find any data on inequalities in relation to black and ethnic minority children and young people?
So there is one report which has been done based on the Far Away from Home study, which did indicate that during the first lockdown that there was actually a decrease in the admission of young people from black and ethnic minorities. However, during the second lockdown, there was an increase. So that the hypothesis from this paper is that during the first lockdown, this was a cohort of young people who actually ended up accessing services less. So earlier intervention towards their mental health wasn't able to be put into place, and that became more apparent with the second lockdown, when the severity of their mental illness became such that it was no longer possible for them to stay where they were, and they required the support at a higher level at that time.
At which point they were at a crisis point?
Yes.
Thank you. My lady, I'm about to move to a new topic. I don't know if that's a good time to take a break.
Certainly, I shall be back at 3:00. I hope you're warned we take breaks.
Yes.
I hope you approve.
A lady. Dr. Northover, can we move on, please, to look at changes to discharge from CAMS inpatient care during the pandemic? And could we go, please, to page 31, figure 10 in your report? And we can see there, plotted for England, monthly discharge rates from CAMS inpatient services. We can see there a rapid spike, a rapid rise in monthly discharges at the onset of the pandemic in around March 2020. And you attribute this in your report to the NHS directive to free up bed capacity at that time. Was that directive directed, so far as you're aware, to mental health units as well as to acute hospital?
So whilst the directive may not have been directly attributable to mental health inpatient units, I think at the time there was a consideration that the reduction in discharging patients wasn't just around freeing up bed capacity. It was around the potential risk of staffing issues, and within mental health units, would we be able to maintain all the beds that we presently had at that time?
Thank you. And then after that spike, we see a very rapid drop in the number of discharges in April of 2020, and then a more gradual trend of decline throughout 2021 and 2022. This graph is based on data from England. Is it right that that trend of declining discharges was in fact consistent across the 4 nations of the UK?
Yes, as far as I'm aware, yes.
Have you identified any evidence that young people were being discharged during that spike too early and while still unwell in order to either to free up beds or for any other reasons?
Yeah, and we, in contact with the units that I spoke to, there was a concern that some young people were being discharged when perhaps their treatment hadn't been completed, and at a time when potentially the community intensive support teams were not in a place to manage all of the young people who might have been referred onto their services.
If a young person's discharged effectively too soon before their therapeutic stay has really completed, what's the likely future consequences of that?
The most likely future consequences is that they need to be readmitted into an inpatient unit. And I think that's what we see when we look at this graph, because we see a drop-off and then we see a slight rise again when we think, okay, potentially we're seeing some of those young people who were initially discharged being readmitted again at that point.
Can we look, please, at the figure that appears on that page, but below figure 11? And this is the average length of stay, and we can see a gradual increase throughout the relevant period. Again, we have it in the mean and the median length of stay here. Is it right that this increased length of stay for patients was correlated to the decline in monthly discharges?
It does appear to be, yes. Yes, I think certainly we can say that one of the reasons for the decrease in discharges is an increased length of stay. The other reason is likely, as I said earlier, that there were less beds available.
And you identify in paragraphs 95 and 96 of your report that the rules about self-isolation impacted discharge and length of stay, particularly in relation to trial periods of leave prior to discharge. Could you enlarge upon that, please, and explain how trial periods of leave were generally utilised prior to discharging a patient?
So, as we all know, children and young people are rarely discharged into a flat on their own. They are almost always discharged back into a family or into carers. And that shift from an inpatient unit back into the family or carers environment is something that it's difficult to predict how that will go. So you often have periods of extended leave where a young person will go back home, we'll spend a night, maybe 2 nights with the family, and then come back into the unit to have an assessment of how that went. And that gives an opportunity to then adjust the discharge plan to make sure that it's most appropriate for the young person and the family.
So it's effectively a trial period back at home, but before formal discharge has taken
Yes,
place.
I mean, it's a little bit more than a trial period. It's part of the treatment plan, but it can absolutely be seen as a trial period.
In terms of the impact of longer stays on the unit, on the outcomes for patients, Dr. Lockhart has stated in her witness statement that prolonged admissions are associated with poorer outcomes. Could you enlarge upon that for us, please?
Yeah, so again, this was some data which came out of the GERF report as well, which is the longer you spend in a CAMHS inpatient unit, the worse your long-term outcomes when you look at it, you look at that young person's trajectory over months or years.
That seems perhaps a little bit surprising because clearly it's supposed to be a therapeutic environment that they've gone into. So what's the reason for that?
I mean, there's a number of reasons. So first of all, if it takes you longer to recover, you've probably got a more severe presentation in the first place. So that could be one of the reasons why it takes it takes longer to recover. The second part behind it is because of the restrictive nature of inpatient units. So when you are in an inpatient unit as a young person, you don't have the freedoms that you usually have. As I previously mentioned, you don't have the opportunity to leave the unit when you want to. You don't meet your friends. You get separated a little bit from your family. And the longer you're in an inpatient unit in that way, so I'm trying to avoid using the word institutionalised because that's not what I mean, but the longer you are within an inpatient unit, the more challenging it appears to go back into the environment that potentially was part of the reason that you got admitted in the first place.
So children were spending longer in inpatient units before discharge. Can we look now at some of the changes that they would have been experiencing whilst they were staying in the inpatient unit and how that might have impacted on inpatients and their progress? First of all, there were some changes to staffing during the pandemic and overall a reduction in the number of staff that were available. Is that right?
Yes. So staff sickness did lead to an increased use of agency staff. And decreased staff levels on the units. And agency staff may not know the unit as well as regular staff, and the young person may find it more difficult to establish those therapeutic relationships if you have a continuing changing staff member who's trying to support that young person.
In terms of the numbers of staff that were available during the pandemic, you set out the NHS benchmarking network data on average staffing numbers. So they're quite intensively staffed inpatient units. On average, 35.2 staff per 12 beds, and in an eating disorder unit, 33.7 staff per 12 beds. In terms of reduction of the number of staff who are available then, whether that's due to illness or self-isolation rules, what would the impact be of a unit being understaffed?
So an understaffed unit is unlikely to be able to have meaningful activities going throughout the day. So if we're looking at meaningful activities, if you're a young person, you're admitted into an inpatient unit, staying in your bedroom continuously isn't going to be the type of intervention that's going to help you. So you need to have these structured activities throughout the day, which may be therapeutic in some circumstances, such as group therapies, maybe trips and visits out of the unit in other circumstances, but may also be things such as having sporting activities, having other sort of activities that the young people can get involved with as a group that are not necessarily overtly therapeutic. If you don't have the staffing levels for that, then you end up in a situation that you might be able to maintain some of those therapeutic activities, but in between those, there might be very little for the young person to do, which in itself can lead to a less beneficial inpatient admission.
So that's an impact on the quality of care, really, for the patients at the time. Are there potential impacts on patient safety from understaffing?
For staffing levels to get to the point that it has an impact on safety, it does have to be quite extreme. So that would be at the point where a unit feels that it's no longer able to provide one-to-one staffing for young people who require to be under that constant level of observation. What we did see within England is when staffing levels started to get to the point that there was a concern around safety, a trust might have made the decision to say, okay, we're going to close one of our units so we can ensure that we've got enough staffing level on another unit.
Can we perhaps have a look at the graph that shows that? That's figure 7 on page 26 of your report. And we can see that in 2020, between 2 and 7 units were closed at any one time. However, you have observed that the CAMS inpatient units in the devolved nations remained open throughout. Do you know why there was this discrepancy between England and the devolved nations in that regard?
I haven't. It's not something I can definitely answer, but I do feel that part of the answer is the staffing plans that were potentially put into place. So within England, most wards are part of a unit that will have more than one ward. So staffing cover between the wards is something that's possible. So your staffing emergency plans would be, let's use staff from another ward to cover. If you're a single ward on a unit, then your staffing plans will involve where can we find other staff from within the system that can support. So that might be thinking about the community teams or the crisis teams. So it's possible within the devolved nations to keep their less number of units open, that they relied on the staff from the community services to come in and make sure that safe staffing levels are always in place.
So you mentioned their staffing emergency plans or contingency plans, and in your report you refer to the fact that some independent providers, and I think it's right that a number of inpatient psychiatric units are provided not by NHS providers. They're paid for by the NHS, but they're provided by independent providers. Is that right?
It is, and actually the way that these independent providers are commissioned and used is slightly different to other areas of the NHS. So whilst they are units that have effectively been built and staffed by independent providers, all of the young people in those units are NHS patients. And it's a commissioning arrangement that they will provide the NHS services rather than it being an independent unit that you place somebody at a point of need. However, those units themselves are often single units, and they are often in isolation of any community service that could provide that type of emergency staffing that I described that the devolved nations may well have been able to use. So that does leave those units at a greater risk of having unsafe staffing levels.
And you set out in the report one independent provider unit which reported that its staffing contingency plan was to provide basic training for the reception and administrative staff to provide cover on the ward if that was required. What were your views about the appropriateness of that arrangement?
Thank goodness it never had to be implemented.
If we can move on to deal with the impact of infection prevention and control measures in inpatient CAMS units, and in particular the rules around social distancing and self-isolation for new patients. Is it right that throughout the UK during the relevant period there were isolation rules for all new admissions onto inpatient CAMS units?
Yes. Yeah.
So that meant that the young person had to isolate for between 7 and 14 days at various points throughout the pandemic. Yeah. What was the impact of a period of isolation on a young person's mental state?
I was very fortunate to be able to hear the evidence provided by the impact witness earlier, and I think it's just building on what she said. It is a terrible time for a young person to be placed in isolation when they're at their most distressed from a mental illness that means that they can no longer be at home. To be placed in isolation at that time with a mental health nurse outside your room inevitably had an impact in terms of the distress of that young person, but also the time that it would have actually taken to get them the appropriate therapeutic input, and also for them to be able to be engaged within that therapeutic milieu within the unit.
You've also set out that because of the self-isolation rules, there were restrictions on the number or frequency of visits from friends and family. What is the importance of family visits for mental health inpatients?
It's crucial. Sort of family and carers. Some young people may be admitted where actually they haven't got family or don't have access to the family, but I think it's family and carers is absolutely crucial. I think any mental health presentation within a young person doesn't just affect the young person, it affects the whole, the family and carers as well. So it's about how the treatment needs to involve those systems and not just an individual. So delaying or not enabling that to happen has a negative impact on the therapeutic delivery of care.
So it's not just that it's nice for the inpatient to have some visits and someone come along and keep them company, but it actually very much impacts on the therapeutic progress. Is it right that in pre-pandemic times, family therapy would be part of the inpatient treatment and take place on the unit often?
Yes, absolutely. And I would have to go and check the staffing numbers, but every child and adolescent inpatient unit should have a family therapist.
You've also identified that because of the social distancing rules that existed on the inpatient units as everywhere else, there was less contact between patients, between inpatients during the pandemic, less use of communal areas, and a need to divide patients into bubbles. To what extent is contact with other inpatients helpful for those children and young people? And did that reduction in contact impede their progress?
Yeah, and again, that contact is very important. It's very difficult for a young person to fully recover or understand their mental illness if they're doing that in isolation. So being able to have those conversations and normal teenager time with other people whilst you're in an inpatient unit is part of the therapy. And that, when I sort of describe the therapeutic milieu, that's sort of what I'm trying to describe there. It's about how the young person can be on a unit which is friendly and supportive and is able to provide the advice in the way that we all hope that we're able to provide in home to our own children.
Also, I think there was a reduction in group therapies that were able to take place for the same reasons, because of the social distancing rules. If there wasn't a room large enough to accommodate everybody with the appropriate 2-metre distance between them. Was there an observable effect or impact on children and young people from not being able to access group therapy?
For this, I would just have to hypothesise, yes. We do know that those units that weren't able to provide group therapy because they didn't have a large enough room felt that was a big hindrance to their delivery of care. However, actually finding clear evidence for that, I think, would be much more difficult to do.
And we've heard that there was a move to delivering therapies online or remotely. Did that happen as well on inpatient units?
Yes, it did. So you would find that the therapists, so that the psychologists on the unit may not be going into the unit to provide the therapy, but would be doing that remotely from their home, beaming into the inpatient unit.
And are there drawbacks and benefits to remote delivery of therapy for these cohort of patients?
Yes, absolutely. And the drawbacks and the benefits can vary from presentation to young person to type of therapy. So it's quite difficult to unpick. So there's certain therapies such as psychodynamic psychotherapy or an art therapy, which is going to be much more difficult to deliver remotely than a manualised, structured cognitive behavioural therapy. And then a young person with social communication difficulties may find remote therapy easier, or they may find it more difficult depending on the makeup of the young person. But absolutely it would have an impact.
And was there any national guidance provided on that during the pandemic in terms of identifying what kind of patients and what kind of presentations and what kind of therapies would be most appropriate for remote delivery of therapeutic interventions?
No, it was very much more a blanket that if you can work remotely, you should be working remotely, rather than thinking more closely around what would work remotely and what wouldn't.
Do you think that's an area in which national guidance would be useful in the event of a future pandemic, or generally with a general move towards remote delivery of therapies?
Absolutely, yes. I think it's an area that probably needs the research first. I think it is actually a very complicated area, and it's quite easy for us to make assumptions about what will or what won't work. But I think whilst we've got an opportunity, we should be exploring the evidence behind it and then being able to put that into national policy.
Staying then with the impact of IPC measures on inpatient wards, you've set out the possibility on an inpatient ward and with these particular children and young people who may pose a risk to themselves, that PPE could actually be used for self-harm.
Yes, and this was a specific example from one of the units that I talked to, where they had a young person who was at risk of self-harming by removing small bits of wire from the mask.
So that's the part that goes over the nose and enables a closer fit.
Yeah, and the other thing to remember is PPE has string attached to it, so again, that in itself can bring a risk of tying of ligatures.
Is it also right that, particularly in terms of mask wearing, that can impact on children and young people in terms of establishing a relationship of trust and understanding with the staff on the unit?
And that's certainly feedback that we received, is that it can be much more difficult to establish that therapeutic relationship. However, we did on occasions get feedback which suggested that young people and the therapists felt much safer when they had the right levels of PPE, which allowed them to engage better in the therapy. But overall, it was deemed to be a barrier. So
you've identified in your report that the COVID rules in particular impacted on children and young people in terms of reduced visits from families and carers, the self-isolation periods, and reduction in staffing levels and less continuity of care. Were you able to identify any measures or guidance at a national level, or indeed at a trust level, that were aimed at mitigating those impacts?
I'm tempted to just say no. But I think that the fact that I'm sitting here not able to recall any is probably an indication itself that if there was, that the way that it was communicated was probably, the communication of that was probably outweighed by the communication of the safety, the social distancing rules and the PPE rules.
If we can come on to look at some potentially positive changes or initiatives in response to the pandemic, I think your research did identify some efforts to establish alternatives to inpatient admissions, and in particular community crisis hubs. Can you explain how they worked for children and young people in the community?
Yeah, and this is certainly one of the areas that COVID has allowed to develop within mental health services, and that's about how do we make sure that we've got the right support in the right place for young people. And there's a recognition that actually going to an emergency department with within a mental health crisis may not be the right place for you to go. And during COVID, it was identified that it absolutely wasn't the right place to go, because you didn't want to be in an emergency department with people with physical health problems, probably COVID around the place, when you could be supported and managed somewhere else. So a number of trusts tried to establish crisis hubs where a young person or an adult could go to have their mental health crisis needs met without them having to go into the acute paediatric ward. I think Great Ormond Street was one example of this. They had great feedback, but it's an area that doesn't seem to have really become as established as was expected at the time that during the COVID time when the benefits were being realised.
Have you been able to identify why they don't seem to have been continued or taken up?
I think these are complex systems to set up. If you set up a hub for people in a mental health crisis, then there's the risk that somebody who has got a mental health crisis and a physical crisis isn't actually treated in the right place. So you need to have some very good working policies with the acute hospitals. I don't think that these are these types of hubs are quite resource intensive. So you need to resource them with quite a large number of staff who are going to be working there potentially 24/7. And the question is, where are these staff going to come from? And I think the trusts will always want to be able to make sure that there's an evidence base before they do something that's potentially resource intensive. And I'm not sure that the evidence base was there at the time. And whilst there was positive feedback, I'm still not sure we have the clear evidence of the benefits of these hubs. I hope we do, because I hope it's an area that we get the evidence for.
If we can move on, please, to lessons learned and recommendations for future pandemics. You have set out that whilst the response to the pandemic, and in particular lockdown, and specifically closing schools, these were known risk factors for children and young people's mental health, but that nevertheless the pandemic preparedness plans did not appear to have included any plans for mental health services prior to March 2020. In your opinion, how should pandemic planning have addressed a predictable increase in demand for children and young persons' mental health services?
I mean, the first part to this question, which is around sort of the social determinants of health, we understand the social determinants of health, and we should be addressing those anyhow. And I think if we don't address those, then we have to expect a pandemic will make those social determinants worse, and that will have an immediate impact. So for that not being in any pandemic planning is a bit of an oversight. When we know that it's going to happen, we then need to start thinking about what are those protective factors within the community that we need to be considering. School is a huge protective factor for children and young people. I know there's plenty of children who don't enjoy going to school, but it's another social safety net to understand when children are struggling, and another route for children to start getting help. So we need to be thinking in the future, what do we do with schools so we don't remove that safety net? Or if we do remove that safety net, what can we put in place? We then have conditions such as eating disorders, which within the report, we can predict that eating disorders will significantly increase during a pandemic because it hits all of the risk factors for an eating disorder. So what pre-pandemic planning can eating disorder services actually do to make sure that they can increase a predictable so they can meet a predictable increase in demand? And just having to think through that as a service should enable them to put some relatively straightforward plans in place to start managing that demand.
Given that an increase in demand for mental health services is predictable in a pandemic, as you've set out, do you think there needs to be a surge capacity plan for mental health services as there was for the anticipated surge in demand for acute hospital services?
Yes.
And in terms of the inpatient CAMHS provision across the UK, was there sufficient capacity to meet demand before the pandemic?
No.
And so, to what extent do you think the current state of the inpatient CAMHS service has ramifications for how resilient the service is in the event of a future pandemic?
So I'm thinking about the inpatient aspect and the inpatient side of any planning for the future. It's about how can we reduce the need and demand for inpatient services. If we had the crisis and intensive home treatment team services that we now have at the time of COVID, we probably would have seen even less young people needing an admission because we would have had a viable community alternative. But that doesn't mean that we should stop here. We should continue to look at that community offer and how can we continue to provide the care that's required and needed in the community, and potentially get ourselves to a position where we need less and less inpatient beds. We're never going to need no inpatient beds, but we can potentially have less, and for it to be much clearer and much better defined about who should be admitted and why, and what that treatment looks like.
Dr. Northover, you've included there a number of the recommendations that you've identified in your reports. Are there any other areas where you would like the inquiry to consider a recommendation in relation to inpatient CAM services in the event of a future pandemic?
So the first one I'd just like to mention, I know I've touched on it briefly when you asked me earlier, but it really is, as the policies are released during a pandemic, which are understandably there to support the demands on the acute hospitals, I think there has to be a very, very clear process to make sure that there's a quality impact assessment of those policies on mental health inpatient units as well. Because even if it's a policy that we can't change, we should at least at that point know what the impact on quality is going to be. So once we're past the crisis point, we know what the issue is and what we may have to deal with at that point in time. The other thing which I think we need to mention is the inpatient units themselves. The fact that inpatient units had to, some units didn't have enough room to do group therapy is something that we have to prepare for in the future. Our units have to be designed in the way that they can manage a social distancing situation in the future. We're already at a position where I think there are very few, if any, rooms that have more than one person in them on an inpatient unit, which is fantastic, but we just need to make sure those communal areas and the therapy rooms are large enough, and that we have the visiting facilities for families so they can come when there is social distancing to still see their children and support with the therapy.
Thank you very much. I've no more questions for you, Dr. Northover.
Thank you very much, Mr. Field. Mr. Pisani, who's to the back to your right, but if you could make sure your answers go into the microphone, I'd be grateful.
Doctor, I ask questions on behalf of Mind, the mental health charity. I say I ask questions. Almost all of my questions have already been asked and answered, but I may be able to formulate some opportunities for you to perhaps expand on some of your shorter answers. The first is in relation to capacity, capacity to meet demand. You've already been asked and answered bluntly in relation to whether capacity was there to meet demand even before the pandemic. Can I ask specifically in relation to eating disorders, please, Doctor? I am looking at the part of your statement that deals with eating disorders at paragraphs 164 and 165. Where you say at 164 what we've, I think, already established, that following an initial decrease, eating disorder presentations rose significantly during the COVID-19 pandemic. And then at paragraph 165, you note that prior to the pandemic, eating disorder services had already been struggling to meet demand. You also more generally report at paragraphs 104 and 158 that the staff that you spoke to identified a feeling that there was decreased capacity across the sector. And there were even ethics committees set up to meet the potential for reduced capacity and increasing demand causing crisis. How then would you respond to an assertion that during the pandemic, in specific relation to children and young people's mental health services, demand never exceeded capacity?
So I would. So again, the first part of the question is whether we're looking at inpatient care, because if we're looking at inpatient care in particular, then you can manage your demand because your demand is how many beds you've got. So by seeing young people spending longer within inappropriate settings before they're admitting would suggest that we weren't meeting the demand for inpatient for inpatient beds at that time. I'm not sure whether that's entirely answered your answer, and I'm just going to finish saying that and then turn around and look at you again.
If you have anything that you wish to add, then please do. I did specifically mention eating disorders, and I wonder whether you'd be able to comment specifically on the demand and capacity to meet that demand during the pandemic in relation to eating disorders.
So again, with eating disorders, one of the challenges with eating disorders, and the reason why we saw an initial drop-off, is for young people staying in their family homes and the weight loss not being recognised in the first instance. So it may well not be that demand, we could meet demand in terms of the young people being referred, but that doesn't mean that we were being referred everybody who had an eating disorder. So then once we got past that initial phase of young people deteriorating significantly within their bedrooms, that's when we suddenly saw a significant increase in demand, at which point I think all services were starting to recognise that they couldn't meet the demand for the referrals for eating disorders.
Thank you. The second topic that I would wish to raise has also been expressly asked of you already, and that's about what you say at paragraph 122 of your report about independent providers reporting greater challenges in developing staffing contingency plans because they were more isolated and not able to call on community mental health staff, community teams to provide emergency cover. Are you able to explain what you mean by isolation, though, in that context? Do you mean geographical isolation or isolation from NHS services, either inpatient or community, or both?
Yeah, so it's certainly not a geographical isolation. It is more an isolation from the provision of other services. If I look at the trust that I work in, Berkshire Healthcare, it employs nearly 6,000 people. So that's a large group of people that you can pull on and identify those who have got the expertise and the knowledge to support an inpatient unit if it's getting to the point that the sickness on that unit is not allowing enough safe staffing levels. The independent units may have they may have more than one unit, but they're likely to be spread over the country, and you're not able to have that large resource of staff within close proximity or with the right level of skills to come in and support in the unit. And that's why, as I mentioned in the report, some of these units were having to resort to looking at the staff that they did have that they could pull in, and how can we upskill those staff to the best of their abilities to provide the best care that they possibly could, which at that time may not have been what we would consider to be good during a time outside of a pandemic.
I think we're going to have to leave it there, Mr. Pashley.
Very well. Thank you, my lady.
Thank you very much. That completes the questions we have for you, Dr. Northover. Thank you very much for your help in producing your written report and for your help in giving evidence today. I'm very grateful.
Many thanks.
Ms. Carey.
Thank you, my lady. Before we conclude this week's proceedings, can I invite you please to publish a number of additional statements and documents at this stage. That includes 3 statements on behalf of Royal Colleges. Dr. Edward Morris, who is the former president of the Royal College of Obstetrics and Gynecology. Dr. Catherine Henderson, who is the president of the Royal College of Emergency Medicine. And Sir Andrew Goddard, the former president of the Royal College of Physicians. In addition, there are 4 impact witness statements that we'd invite you to publish. They are from Vivian Wilkes, who is a member of the Disabilities Charities Consortium. She is registered blind and was sent a shielding letter in an inaccessible format during the pandemic, and she speaks to that and other difficulties she had in accessing healthcare. Kafalit Adekunle is a community matron and a member of the RCN, and she describes the difficulties that she had with PPE and the impact of the pandemic. Adrian Warnock, a member of the Clinically Vulnerable Families Court participant group, isolated from his parents during the pandemic, and he attests to the impact of shielding on him. And your ladyship will recall yesterday hearing from Natalie Rogers, in addition to the speaking on behalf of the long COVID core participant group, she made an impact statement which sets out her own personal experience. I invite you to publish 3 chronologies provided by the long COVID groups, which sets out a number of documents they provided to government, work being done with their membership, and indeed other work they have undertaken to provide impact evidence to the inquiry. Can I also invite you to publish the expert report from Professor Christopher Gale and Dr. Nadaraja? They are the experts in ischemic heart disease. And finally can I invite you to publish an additional statement from Professor Jonathan Wiley. Your Ladyship will recall on the 10th of October he gave evidence and was asked about whether the Resuscitation Council had received reports of inappropriate or blanket DNA CPRs. He indicated he thought there had been reports of a trust behaving in this way. And over the course of the 2-week break, the Module 3 inquiry legal team asked Professor Wiley for further details about that evidence. He's provided an addendum in which he clarifies the example he was talking about in fact related to a restrictive approach to the circumstances in which CPR should be administered, and not in fact to an example about blanket or inappropriate DNA CPRs. Can I ask your Ladyship, in order to have his evidence in its proper context, for you to publish his statement, which is INQ 474448.
I authorise publication of all statements.
Thank you very much, my lady.
Thank you very much. That completes the hearings for this week. I'll see those who have to attend and those who are interested on Monday, the 4th of November at 10:30.
Thank you.